All right, so with that, let me introduce the next session, which will focus on risk mitigation and bundle payments, when to hold them and when to fold them. And so to guide the conversation, we have three speakers. Lily Pazan, who is with NYU Langone Medical Center, where she joined in 2010 after receiving a master's in public health from Columbia. And in her role, she's responsible for supporting data analytics reporting and monitoring the demonstration projects. Next will be Jonathan Pierce. And Jonathan is the founding principal of Single Track Analytics and works with clients across the country to apply analytics to advanced payment systems. With more than 3 decades in healthcare financial consulting, he has worked with many, many different healthcare organizations and focused very much on models 2 and 3 of the bundle payment for care improvement. And then finally, Jessica Walrad serves as the American Association of Medical Centers Alternative Payment Teams Policy. So the AAMC is really the organization that represents the large academic medical centers in the country. And she supports their involvement in particular in the bundle payment for care improvement program using data analytics. And I think what's interesting with this session is that there have been many lessons learned from and within the bundle payment for care improvement, and I think some of that was discussed in yesterday's track, but I think for everyone to kind of set the stage also for our following speaker who comes from CMS and will discuss the current state of the bundle payment for care improvement, where it's going, it's important to set the stage and help people understand that there are pros and cons, tensions within the program that physicians and hospitals are dealing with. So with that, no. Yeah. Yes, that's on. Yeah.
All right, a smooth start of this presentation.
Oh, wait a second. Try to do two things at once. Go. Lily.
Okay. They go down.
Jessica, you should.
All right, good?
Yeah.
All right. Everyone, I'm Jess Walrad from the Association of American Medical Colleges, and the AAMC is a convener in the Bundle Payment for Care Improvement Initiative, and along with DataGen and John from Single Track Analytics, we support the involvement of about 25 teaching hospitals that are engaged in implementing Model 2 of BPCI. One of those hospitals, NYU, is here with us today. So one of the key things that John and I do for these hospitals is help them decide which of the 48 episodes they should take risk for. And on the screens you see actual financial projections, episode specific, for a hospital in our group and their projected Medicare savings or losses across a year in this program. So these are back of the envelope calculations taken by comparing a hospital's current spending and utilization to their baseline target price. So what you see here is that this hospital has an increasing cost trend. You might look at this and think, why would I take risk for CHF if I'm projected to lose $1 million in Medicare payments in 1 year? Well, using the tools and techniques that we're going to talk to you about today, this hospital identified sufficient opportunity to generate savings and ultimately decided to go at risk with some of these episodes. So today, our group is going to talk to you about how you can identify and manage risk. And we're going to do that by having John start out by discussing a framework of analytical concepts that you can use to identify risk. Lily is going to talk about how NYU used those concepts to make decisions about their own participation in the program. And then I'm going to wrap up by sharing some lessons from AAMC's entire convened group.
didn't quite plan it this way. This was the little microphone trade-off thing. So when we talk about advanced payment systems, we kind of use the lens of the vision and the game. So the vision is what policymakers, what clinicians, what non-healthcare journalists see, which is the clinical side of the payment system. It's care improvement, readmission reduction, post-acute care management. It's all the stuff that's supposed to happen. The other side of this is the game. This is where Jess and Lily and I and our friends and a lot of you probably live. And this is the rules. This is payment system rules. This is reconciliation, target rates, base periods. This is all of the stuff that sits around the structure. And the part of this is you can win, you can achieve the vision, and you can lose the game. Okay? And in a lot of cases, Jess and Lily will be able to tell you some cases where NYU pulled out of an episode because they could achieve the vision, they couldn't win the game. We've had some of the AAMC hospitals that had the same situation. You can have a whole payment system in which you can achieve the vision and lose the game. People might argue that 2/3 of the Pioneer ACO participants didn't pull out because they couldn't achieve any type of clinical change. And there's different types of risks in either of these categories. Vision risks are the kinds of risks that you'd expect to find. This is a failure to achieve what you're trying to achieve. Having excessive readmissions, inability to control post-acute services, increasing complexity of the patients. But the game risks are things like your base period not being aligned with what your true costs are because of some aberration during the base period. Target rate adjustments that aren't keeping up with what's actually happening in your medical technology. I'll show you some examples of where the CMS discounts interfere with achieving with winning the game. So the BPCI program gives you a certain number of risk mitigation strategies. We'll talk about some of these. You can mitigate risk by choosing different episode lengths. You can mitigate risk by choosing the different risk tracks that are out there. You can combine episodes together, not necessarily in the BPCI structure, but in your own structure to try to minimize risk, to take an episode that by itself wouldn't be viable, but combined with other episodes will be viable. And you can find the ultimate risk mitigation is not to participate in a particular episode. Okay? So let's take a look at risk and opportunity. Anytime there's variation, if there's no variation, there's no risk or opportunity. When there is variation, the issue that we get into is whether that variation constitutes risk or opportunity. Risk you want to shield yourself from. Opportunity you don't. So opportunity is predictable. It's where you have consistent patterns of care. The care looks the same pretty much from quarter to quarter. It's planned. People don't show up in a post-acute setting spontaneously. They're probably sent there. Care plans exist, as you've heard over the last couple of days. Risk is random. Risk is the trach patient who shows up and stays for 2 months and costs you $200,000. It's where there's ineffective care, or your major joint strategy might have been to reduce post-acute provider utilization, and all of a sudden you've got a bunch of readmissions that you weren't expecting. Or where there's no care plan at all, where you may be able to reduce readmissions up to 30 days, but you have no clue what you're going to do in the period going past that. So the first thing that we look at in terms of episode selection is looking at episode volume. If you don't have enough episode volume, things are just going to deteriorate statistically. And we decided that you needed to have, if you're going to participate in a single episode, we decided you needed to have 100 episodes a year. Below that, you get into a situation like this, where you're getting quarterly variations. This is quarterly, so this is what your reconciliation would look like. And you can see that in the lower volume episode, it's varying up and down significantly. It's very, very, very hard to figure out whether you're doing well there. And not only is the total varying, but the components are varying, so it's difficult to see whether your care management programs are working or not if you have low volume. So once you get past that, when we start digging into the data, the questions that we ask are two. What's there, and what can you do about it? And we start looking at the data. Those are the things that we look at. So let me show you how that works. This is an episode composition graph for major joint replacement. Each of those vertical bars is an individual episode. Blue is index admission. Yellow is home health. Green is SNF and inpatient rehab. Okay, what's there? Green, a lot of green. Okay, that's where you're going to be looking at. What can you do about it? Well, if you listen to any of the speakers over the last couple of days, which I'm not going to talk about, hopefully you have an institutional strategy for dealing with post-acute care. And if you have that, that's opportunity. That's not risk. Let's look at CHF. What's there? Red. Red's readmissions. Okay. But it's a relatively consistent look at readmissions. You've got a lot of readmissions. Hopefully a lot of those readmissions were in your base period, so it's going to balance out. You don't have any really bad train wrecks. And hopefully you've been listening over the last couple of days and you have a decent readmission mitigation strategy, and this hopefully is opportunity for you and not risk. So let's dig a little bit further. This is CHF episodes over the first, second, and third 30 days of the episode. Okay, what's there? More specifically, what's there? What's there is a lot of red in the last 60 days of the episode. And when I ask the question, what can you do about it, I get two different answers from the clinicians. In some cases, clinicians will say, we can handle 30 days, but we don't know what's happening to that patient 60 days, 70 days after the episode is over. And the other answer I'll get from clinicians is you have to. That's what you're supposed to be doing in this program. Okay, and the clinical leadership at AAMC takes a second position, so we're using 90-day episodes. But if you can't do anything about that second 60 days, that's risk. And your risk mitigation strategy there would be choosing a 30-day episode. Let's look at something else. Let's look at major joint replacement. It's the same type of graph. Well, here, what's there? The answer is not much. Okay, there's not much opportunity there. There's not much risk. So we pick a 30-day episode there because there's no opportunity in the last 60 days. Yeah, except for what? Your discount for a 90-day episode is 2%. Your discount for a 30-day episode is 3%. You can participate in a 90-day episode with almost no additional risk and pick up a percentage point of discount. Okay, so there's another risk-reward trade-off. You can pick up a lower discount without picking up any additional risk. Okay. And this is a vision thing. We're not getting into the rules of the game too much here. This is what clinical care actually looks like in these episodes. So here's another risk thing. This is a different point. This is CHF. The graph is showing the average episode cost in a quarter for CHF. And this was a CHF facility that actually had enough volume. And this is quarterly episode variation. So if your targets were flat, this is how much your NPRA is going to vary on a quarter-to-quarter basis. And the thing that's amazing there is look at that amount of variation. If your CFO sees this, he's going to be one of the patients in the heart failure diagnosis. All right. And the point here is not that you should or you shouldn't play, but you got to play this for the long game. And we had a couple of early participants who said, I want to look at my first reconciliation and decide whether I'm going to participate in this program or not. Well, it's going to matter an awful lot which one of these you looked at to decide whether you're going to continue to play. So the issue here is you've got to be playing for the long game. You've got to be in this for a while. This is like going to the casino with $10 or $10,000. Okay, you're going to be out real quick if you do the short game. And this is a vision issue here. This has nothing to do with the rules of the game. Let's look at something else. This is cardiac valve. What's there? Blue. A lot of blue. Index admission. What's not there? Anything other than blue, pretty much, right? Okay, there's not an awful lot of post-acute cost there. Only about 13% of the episode is post-acute cost. Why is that a problem? Because you've got to pick up your discount, the CMS discount, from that entire episode, and you've got to pick it up from 13% of the episode cost. And what that means is you've got to get a 6% post-acute reduction in post-acute cost to pick up that 2% discount. That's not to say you can't succeed in cardiac valve. NYU is succeeding in cardiac valve. It's to say it's an awful lot more difficult to succeed. And this is a game issue. This is purely because of the way that discount is structured. If the discount were different, this issue could go away. Okay? And in fact, you can see in some of these episodes, if you're participating in valves or participating in CABGs by yourself, it's an awful lot more difficult to achieve a savings in these episodes. You need a 6.3% reduction in this case to achieve the 2% discount, whereas in CHF, there's an awful lot more post-acute cost there. And you can achieve that with a much lower reduction in post-acute cost. So that's my piece of it, and Lily's going to talk about how they applied this structure at NYU, which is arguably one of the most successful BPCI participants.
Hi, everyone. So I am Lily Bazand. I work at NYU on their payment reform team, which started about 5 years ago now. NYU kind of decided to dedicate resources to kind of payment reform initiatives, preparing for them, predicting them, and then implementing them. So why did we decide to go with Model 2 bundled payment as kind of our first step? As many of you can empathize kind of with those top 3 points, we wanted to kind of incrementally start our care coordination, our care management piece that spanned beyond our hospital walls. But kind of, at least at first, making sure these patients were actually touching our hospital as opposed to the ACO, where they could kind of go anywhere as long as they were attributed to our PCPs. So that's, those were kind of our main reasons. And as we kind of go through this initiative, we're kind of looking to how we can now, move forward with greater population management. So this did kind of, when speaking to our clinicians, this did for them seem to open up risk. They didn't really know what was happening outside of the hospital, especially in that post-acute period. But for us, looking at the data, with the help of John and AAMC and DataGen, we found that this really also opens up a lot of opportunity for us, financial and clinical. So what did we choose? This is something I think everyone can understand. We wanted to go with the more predictable episode type of elective procedures so that we could really put in our care coordination preoperatively through the inpatient, through the post-discharge, the 90-day post-discharge, and we felt that this is where we could really learn how to do this. So we wanted to go with high volume, as John said. We wanted to go with procedures that had a low volume of one-day stays. We did look at cervical spine, we looked at PCIs, pacemakers. We found a lot of one-day stays within our baseline, so we knew if those ever turned into outpatient, we'd be left with the sicker population in our performance period. So we basically chose total joint, spine, and cardiac valve surgery. So kind of what were our cost drivers? Looking at our data, we wanted to pinpoint where do we want our physicians to focus, where do we want our clinicians to focus, and we knew that they just wanted, a few things to focus on, a few targets. They didn't want a whole kind of list that overwhelmed them. They basically just said, give me what I need to focus on, and, I can do it. So we had our physician champion who kind of pushed these levers. We had reports and analytics based around these levers, and this is what we've been basically tracking. So in terms of kind of how we used our data and how we still use it. So this is our kind of average episode cost over time. So the first bar is our baseline, and then the 3 other bars are our performance starting from Q4 2013. So within the episode components for a total joint in our baseline, we had a lot of purple, which was our own kind of inpatient rehab. And we knew that this was something we could potentially change. So when speaking to our clinicians, we asked them, why are you sending over half of your patients to inpatient rehab? And the response was, I thought the hospital wanted us to do this. So we kind of had to change a lot of that culture. And we knew that the market was heading towards, a new type of landscape in terms of payment, and that we needed to do this. So as you can see in the performance period, we were able to change that purple to be much less. And most of that we shifted to home care, some of it, to SNF, but most of it we were able to move into home care with our kind of home care agency partners. And everything else, stayed pretty consistent. Our readmissions are still flat, a little bit of a decline, but it just shows that the rehab wasn't, necessarily changing the outcome of the patient if we're seeing the same kind of quality outcomes. So in terms of joint, what we do see as risk is our fracture population. So far, our fracture volume has stayed consistent with our baseline, which is good. But if it ever goes above our baseline,